Everybody. Okay, I guess I have to click on this continue. Okay, can I have the next slide? All right, so I guess the three major things that I'm going to cover this evening are to describe the current epidemiology of COVID-19, to have you understand the clinical implications of the Delta variant in particular, and then to end with some strategies to help you lower your personal risk of COVID, as well as to lower the risk of COVID transmission in your practices, in your offices. Next slide. So this is a slide that is from the WHO website from September 6th. So COVID continues to ravage the world, essentially. And you can see that the United States is one of those dark areas where there are large numbers of COVID cases, but really no part of the globe has been spared. Next slide. From the US perspective, you can see that much of the country is literally on fire, and the CDC, I think, chose this color purposely because the majority of the United States is undergoing what we consider very high transmission rates. And you can see Hawaii is no exception. So there are very few parts of the country right now that are actually low or even moderate. Next slide. And then this is the Hawaii data. This is as of last weekend. Okay, and so the Hawaii data comes out every day. And just like any other epidemiologic reporting system, there is what we call reporting lag. And you might notice if you follow this carefully, that usually the numbers dip over the weekend, which reflect that people aren't working as well or as hard over the weekend. And then there's a catch up, usually on Monday and Tuesday, that takes into account the weekend cases. Same thing for holidays. So you can see 720 new cases. Okay, and then the test positivity. So this is cumulative test positivity. And then there's some variation by county. Honolulu County always has the largest number of cases. On the other hand, we have the highest vaccination rates. And we'll come back to these vaccination rates at the end as well. So for the ancestral strain of the COVID virus, herd immunity is thought to be about 70%. But as we'll see, the Delta strain has introduced some new challenges. Next slide. And this again comes from the Department of Health. So you can see when really our surge started, and this is broken down into community associated, travel associated, and then it's broken down into travel associated resident and travel associated non-resident. So I think a lot of people like to blame the surge of tourists for the surge that we've seen, but they're not really responsible. And it's really community associated transmission that is responsible for the bulk of the cases. And then these gray areas are where, you know, the information is not yet available, largely because, again, the Department of Health contact tracers have not yet gotten into the specific risk factors. Next slide. And this is the sobering picture of COVID deaths. And this goes back to the surge a year ago. Okay, so we are able to compare our past surge with our current surge. So this is one of the positive things about what's happening overall with the pandemic is our death rate is definitely lower. And you have to attribute this really to vaccination. So you can see that, again, Honolulu always dominates in terms of the sheer numbers. But the height of the curve, okay, in August 2020 is way higher than the height of the curve for deaths. Next slide. And then looking at the cases, and you can see broken down into the age groups. So these are cumulative numbers of cases. Okay, so this is not like a rate, this is total number. So you can see that the majority have occurred in young adults. Okay, and some of this has to do probably with behavioral issues. So I think the older people perceiving themselves to be at greater risk of severe disease have been more likely to take appropriate precautions, sheltered in place, whereas young, healthy people are less likely to practice those behaviors. Next slide. Okay, and then, so this is very interesting also. So despite what I showed you on the last slide about where the highest number of total cases since the pandemic began, this is telling about where we are now. So this looks at the age groups by date. So you can see that in the current surge, really the greatest number of cases are occurring in young adults. Okay, and this again reflects vaccination rates, reflects behaviors, reflects travel, etc. So the older age groups for our current surge are actually make up a lower number of cases relative to the younger age groups. Next slide. Okay, and then this is also interesting. Okay, so this is a breakdown of COVID cases by race. So there's two bars for every racial group or ethnic group. So the green bar is actually the percent of total cases. And then the gray bar is the percent of the state population that the various ethnic groups make up. So to look at the left-hand part of this slide, okay, so here's Filipinos. Okay, so we have a slightly disproportionate number of the cases relative to our proportion of the state population. Okay, but the really striking one is here. Okay, so these are Pacific Islanders, so largely Micronesian, Chukis. Okay, you can see the big disconnect. So they only make up 4% of the state population, but they make up a significant number of COVID cases relative to their proportion in the general population. But again, Filipinos are also higher than their piece of the pie in the state population. Native Hawaiians, again, also slightly higher, whereas other ethnic groups, Caucasians, Japanese, Chinese, again, they're underrepresented relative to their proportion in the state population among COVID patients. Next slide. Okay, then one of the things that has characterized our recent surge is these large clusters that have occurred. Okay, and this goes to, again, breaches of social distancing, large outdoor gatherings, unmasked. So here is a cluster of 23 associated with a wedding reception, 17 cases at a bar that was associated with a concert, sports events. okay, volleyball tournament, having sports events in small, poorly ventilated outdoor spaces, indoor spaces, and then clusters around childcare and early education settings. Okay, and then correctional facilities, and back in June, graduation parties. So that's one of the continuing characteristics of our clusters in Hawaii. Next slide. And then this is, again, by age group as well as percentage of people who died. Okay, so you can see in the younger age groups, virtually no deaths. Okay, but as the age groups, as you increase the age, you can see that among 80-year-olds, the death rate is almost 50%. So definitely age is a risk factor. This is also influenced by the number of comorbidities that people have as they age. So even though there's a larger number of young people getting the illness, their death rate is very low. Next slide. Okay, so I'm going to switch gears a little bit here and talk about the variants. So this comes from Nature. This is a very basic, really diagrammatic picture of what the COVID virus looks like. And probably the most important part of this organism is the spike glycoprotein, because we know that antibodies made to the spike protein are indicative of immunity. So both natural immunity as well as vaccine-induced immunity. Next slide. Okay, and then this is just a picture of the COVID virus binding to the human host cell. So again, the critical role of this spike protein. But for the variants, this is where the mutations occur that render the mutations different clinical characteristics so that they can evade vaccines as well as monoclonal therapy. So monoclonal antibody therapy as well as the vaccines bind or induce antibodies that bind to the spike proteins and prevent entrance into the human host cell. Next slide. Okay, then the variants also have spread across the world. So the alpha, beta, gamma, delta variants, you can see the reach. And this is kind of old data now from July, but I just show this to you to show you that the variants are global. Next slide. Okay, so what really are the significance of the variants? Okay, so the mutations may result in increased or decreased transmissibility. So generally, we're not going to hear about them if they cause decreased transmissibility, but really increased transmissibility is our concern. They can cause either less severe or more severe clinical disease. They can cause mutation, they can have mutations that can escape detection of our usual diagnostic tests. So the way our PCR tests are designed, the majority of them have more than one target, but some of our rapid tests actually have only a single target. So if there is a mutation, okay, in that target site, then our usual diagnostic tests may no longer pick up that mutation. And then decreased susceptibility to monoclonal antibodies. We'll be talking about that in more detail. And then mutations that can evade both natural or vaccine-induced immunity. So what I mean by natural is that, so if you had COVID early on, you likely had the ancestral COVID strain that came out of China. Okay, but the Delta variant, for instance, is now different enough that the immunity that you had to the ancestral strain may no longer protect you against the Delta variant, or the protection that you have may not be complete enough to prevent disease, but again, might still protect you against severe disease and fatal disease. And then same thing with vaccine-induced immunity. And I think that may be, again, why we're seeing a reduction in effectiveness of vaccines and more breakthrough infections. So remember that the vaccines were made against the original ancestral strain. Next slide. So the variants have different nomenclature systems. Okay, there's the alphanumeric, there's the WHO that assigns a letter from the Greek alphabet. And then a lot of people are familiar, just because of the way the media has publicized these variants, of the location where the virus was originally identified. Next slide. Okay, so here are some of the most important variants. So this is what I was referring to, the alphanumeric, okay, the pangolin lineage nomenclature, and then the WHO Greek nomenclature, and then where these variants were originally identified. Okay, and then there's a little bit of difference between the CDC status of the variants and the WHO. So CDC has 3 categories. Okay, WHO only has 2 categories. Okay, so the WHO, is more likely to identify variants that arise in other countries. So you can see, for instance, the Lambda variant, which came out of Peru, is a variant of interest for WHO, but has not yet made it to that status for the CDC. Okay, and same thing for the Mu variant, which is the most recent one to hit the media that we'll be talking about. Next slide. Okay, so this is the CDC classification of COVID variants. So variants of interest, variants of concern, and variants of high consequence. Next slide. So a variant of interest has, again, specific mutations, okay, that impact receptor binding, reduce neutralization by antibodies against previous infection or vaccination, reduced efficacy of treatment, potential diagnostic impact, and then predicted increases in transmissibility or disease severity. Okay, and they have to have evidence that it's the cause of an increased proportion of cases or is associated with unique clusters. But there's limited prevalence or expansion either in the US or in other countries. Next slide. So a variant of concern, okay, differs from the variant of interest in that there's evidence of impact on diagnostics, treatments, or vaccines. Okay, there's widespread interference. There could be widespread interference with diagnostic test targets, evidence of substantially decreased susceptibility to one or more therapies. Okay, and the Delta falls into this category. There's evidence of increased transmissibility, increased disease severity, and they may require one or more public health interventions to contain this variant. So we are dealing now with several variants of concern. Next slide. Okay, then the worst category is variants of high consequence. Okay, so again, much greater impact, and they're of high consequence that would require multiple public health and even international health interventions. And fortunately, at this point in time, there are no variants that are felt to rise to this level of significance. Next slide. Okay, so this is the United States. This is the most recent variant data available. This is current to the end of August. And it's interesting, again, to see the evolution over time. This color is the alpha variant. This is the UK variant, okay, beta, gamma, and delta. So you can see that these are really the 4 strains that are dominant worldwide and in the United States, and as we'll see in Hawaii. But what is notable here is also that once the Delta enters a community, it rapidly becomes the dominant strain. Okay, so this is data going back to end of May. So you can see again, we started out relatively small, but pretty much now the Delta is responsible for 99% of cases in the United States. Next slide. Okay, and just some information about how the state of Hawaii determines what our variant proportion is. Okay, so they started whole gene sequencing in February, so a little bit later than other parts of the country. And they sequence 15 to 20% of positive tests. So they don't test every single positive sample. Also, they tend to add on additional specimens as they get to them. So in a given time period, again, they may not finish up all of this 15 to 20%. And they take these specimens from the commercial labs in all 4 counties. They do the ones that they perform themselves, and they also get some samples from Tripler. So at this point in time, they are not able to do clinical testing of individual patient specimens. And I stress this because this is one of the most common questions that I get, or what, not just from my patients, but from employees at Queens, for instance. What was my variant? Okay, but we'll never be able at this point in time to give you that answer, because these are, again, a sampling of total tests that are positive. And these are only PCR tests. These are not antigen tests. Next slide. Okay, so this is the most current variant report from the beginning of this month. There's always about a 2-week lag. So we're right there in the state of Hawaii with the rest of the country. So we're essentially 100% Delta. Next slide. Okay, and so again, these are the same variants of concern that are circulating on the mainland: the Delta, the Alpha, the Gamma, and the Beta. Okay, so India, United Kingdom, Brazil, and South Africa. And we do have some variants of interest from California and New York still circulating, but again, really dominant Delta. And what is developed is just what came out of India very early, that we're seeing submutations of the Delta. So these are all the ones that start with the AY, but these are submutations of the original Delta variant. So we have those submutations here as well. Next slide. Okay, and then this is just a breakdown by county. So Honolulu County and Hawaii County right now are very similar, but you can see that there was a little bit different path, okay, for Honolulu and Hawaii County to get where we are. But again, once the Delta enters, it becomes the dominant strain. Next slide. Okay, and Maui County, they're a little different, so a little less Delta, but Kauai County also looks very much like Honolulu and Hawaii County. And it's a little interesting here. So this is one of the big outbreaks on Kauai that was pure gamma during that week. Next slide. Okay, so just some information about the individual variants. So the alpha came out of UK and compared to the ancestral strain was thought to be 50% more transmissible. And they definitely had increased hospitalization rates and case fatality rates compared to the original China strain. But activity of the monoclonals are continued to be preserved against the alpha variant. And there was minimal impact on neutralization by convalescent and post-vaccination sera. So the vaccines retain good activity against the alpha variant. Next slide. Okay, then came the beta, which came out of South Africa. Again, more transmissible compared to the China strain. But this was the first variant to demonstrate significantly reduced I guess not really transmission, but activity or response to bamlanivimab, etesevimab, which is one of the monoclonal combinations. And then reduced neutralization by convalescent and post-vaccination sera. So not as good a response to the vaccines. Next slide. Okay, then the gamma, again, came out of Japan and Brazil almost simultaneously, but really not increased transmission compared to the ancestral strain. But again, significant reduction in susceptibility to monoclonals, reduced neutralization by convalescent sera and post-vaccination sera. Next slide. And then this is the mu. Okay, so this one, it's too soon to really know anything about this, but it's being reported widely in the media. But first identified in Colombia, South America, spread to Ecuador as well. And there are sporadic reports in other countries, including the United States and including in Hawaii. And the mu, like the Delta, has multiple mutations. And what is being suggested is that this is much more resistant to monoclonals and multiple vaccines. Okay, and it suggested that the vaccine effectiveness is comparable to the beta variant, so reduced susceptibility to vaccine responses. But again, very early in the game. And unfortunately, a lot of places in South America don't have strong public health reporting or tracking systems. So I think it'll be a while before we really understand the mu variant significance. Next slide. Okay, so I really want to spend the most time on the Delta variant. So it was first identified in India in late 2020 and has resulted in submutant populations very rapidly in India, and again, in every community where the Delta takes over. And it's been verified in 130 countries as of earlier this week. It's now the dominant strain in the United States. And then it, like the mu, has multiple mutations. Next slide. Okay, and this is why it's a bad player. So 40 to 80% more infectious than the alpha variant, which itself was 50% more infectious than the 2019 China strain. So we have a COVID virus that is way more infectious. Okay, and there's some data from China where they've documented that people who are infected with the Delta variant actually had 1,000 times more viral particles in their respiratory tree than the original strain, and they become infectious sooner. Some data also from London, where swab tests suggest heavier viral loads, and infected people, when they exhale out larger numbers of viral particles, and that this virus is more efficient attaching itself to cells in human airways. So the consequence is that if you have an infected person, it can infect way more people at one time, and then also less exposure to this infected person is required for infection. Next slide. Okay, so here's the first study that suggested that it causes more severe disease. So this came out of Scotland. So they had a healthcare data set of over 5 million people, which constituted about 99% of their population. So again, they were very early to the game, April through June. And at that time, 97% of cases were Delta. And particularly hard hit were the young and affluent, okay, who were poorly vaccinated, okay, and again, socializing, large gatherings. So their risk of being admitted compared to the admission rates for the alpha variant was twice as high during this time of high Delta circulation. Next slide. Okay, and there's been other studies since then. So this one was hospitalization, admission, and emergency care for the Delta variant compared with the alpha variant. So this was a cohort study. This came out of England. Again, similar time period, March through May. And 196 patients were admitted with the Delta variant. 24% of them were hospitalized more than 20 days after the first vaccination. And they found a significant increase in the hospitalization risk for the Delta variant compared to the alpha variant, okay, with a hazard ratio of 2.26 and a confidence interval of 3.89 at the upper limit of the 95% confidence interval range. Next slide. And here's another study coming out of Denmark. Again, similar time period. They looked at over 50,000 patients who were admitted for COVID for at least 14 days. 60% had genome data. Okay, and 35% were the Delta variant. Okay, and 44 patients were admitted to the hospital greater than 14 days after their first vaccine dose. So they noted an increased risk of hospitalization of 1.42 times the risk ratio, and this was considered statistically significant. Okay, but the risk of hospitalization was only significantly increased among the non-vaccinated and those who tested positive within 14 days of the first vaccine. So again, these are people who probably did not have an adequate vaccine response. So it's a little hard to interpret this data Okay, and for all of these studies that are basing their relative severity of disease or hospitalization risk just based on surveillance data. So that's the difficulty in interpreting these severity studies that have come out so far. Next slide. Okay, then response to monoclonal antibodies. So I think you folks sent out the, I guess, notice about Regeneron or REGEN-COV being available for mild to moderate disease. So this is the it's from IDSA recommendations. So there's not a whole lot that's available for treating outpatients or people with early disease. Okay, so one of the tools has been the monoclonal antibodies given early to prevent progression of disease. So the first monoclonal that we had available as monotherapy, bamlanivimab, is no longer recommended because of the decreased responsiveness to this drug alone due to mutations and the variants. Okay, so bamlanivimab now in combination or this combination of casirivimab plus imdevimab are the currently available monoclonals, and REGEN-COV is this second combination. So this is for use in people who have mild to moderate disease to prevent them from moving up the severity category, preventing hospitalization. Next slide. Okay, so this is some data that shows the neutralization capacity for these different monoclonals against the variants. Okay, so the delta is in the red. Okay, so again, very early on, bamlanivimab became ineffective against both the delta and the beta variants. Okay, so casirivimab and imdevimab seem to be the best at retaining activity against the Delta variant. So much higher neutralization capacity. Okay, and so this is the combination that constitutes REGEN-COV that's currently being used. Next slide. Okay, and this was something that came out in June. So this is when that combination of bamlanivimab and etesevimab became or was declared essentially no longer effective against the variants based on the data that I just showed you. Next slide. Okay, then the vaccines against the Delta variant. Okay, so the first studies that came out from, again, other countries that had earlier experience with the variants. So we don't even have AstraZeneca available here, but Scottish studies showed that the AstraZeneca vaccine was less effective than the Pfizer vaccine that had 79% real world effectiveness 14 days after the second dose. Okay, comparing it to effectiveness against the Alpha variant. Okay, then in UK, same thing. 2 doses of Pfizer was 88% effective against the Delta variant versus 93% effective against the Alpha variant. Canada showed Pfizer was 87% effective, but I guess the most depressing information came out of Israel. So in their experience, the Pfizer vaccine was only 64% effective against the Delta variant. So remember, the original Pfizer data that came out again for effectiveness against the ancestral strain was really in the 95% range. Next slide. Okay, and more data again about the various variants. Okay, so this is the Delta here. The P1 is the Brazil, Japan strain. And you can see the different vaccines here. So really no data for the Johnson & Johnson in this study, but the Pfizer vaccine, the neutralization against the Delta variant was decreased by 2 times. For the Moderna vaccine, it was decreased by 1.8 times. And then we don't have the Novavax here, but there was also some decrease against the Delta variant. Next slide. Okay, then this is kind of a messy slide here, but this is neutralizing antibodies elicited by the various vaccines. Okay, so these are, again, different donors, different people, but the bigger numbers are better. So the bigger numbers show, I guess, better activity. So you can look at the activity against the different variants, but if you look down at the Delta, activity against the Delta, okay, so this is the Pfizer vaccine, this is the Moderna vaccine, and this is the J&J vaccine. So this was the study where, again, it was suggested that maybe the J&J vaccine was less protective than the Moderna and Pfizer. So, okay, if you look at the Delta numbers here, the Delta numbers here, and then the Delta numbers for the J&J vaccine. Okay, next slide. Okay, then here's some preprint data. So these are not published, these are preprint studies that are online. Okay, what is the impact of the Pfizer third booster dose against the Delta? Okay, so again, this is mainly coming out of Israel right now because they've already given that third booster to people 60 and older. Okay, and Delta still is their dominant strain. Okay, so they found that 12 or more days after the booster dose, there was a greater than 10-fold decrease in the relative risk of both confirmed infection and severe disease. Okay, and then this other study coming out of Israel, they looked at the chances of testing positive after 2 doses versus 3 doses of Pfizer vaccine. And they found that after 7 to 13 days after the 3rd dose, there was a 68% reduction in the risk of infection for 3rd doses. Next slide. Okay, then breakthrough infections. So again, based on what we talked about, the variants, okay, may have reduced neutralization by antibodies generated by both natural infection and vaccines. And this may be the explanation, one of the explanations for what we're seeing as breakthrough infections. So these are people who, despite completing the vaccinations and are 14 days past the 2nd dose for the 2-dose vaccines, or 14 days past the J&J, still getting infections. So again, we know that vaccines are not 100% effective, that the host immune response can be variable depending on age, underlying illness, immunosuppressing drugs. But again, the variants are thought to be responsible for some of these breakthrough infections. Next slide. Okay, and I'm going to skip over that. This is just an outbreak in a Kentucky SNF in April that actually whole gene sequencing data was available, and it was due to this R that had multiple spike mutations. So again, there can be clusters of these variants in long-term care facilities. Next slide. Okay, so to summarize the success of the Delta variant, so we know that it's hypertransmissible. We are thinking more and more that it has a much shorter incubation period of 3 to 5 days. So this is shorter than the average incubation period of the ancestral strain, which was more like 5 to 6 days. Okay, and there's now also mounting data that even the fully vaccinated can spread the Delta variant. Okay, and then they seem to have a higher initial viral load, but in vaccinated persons, people with the Delta variant seem to clear their viruses quicker. So this is one compelling argument of why vaccination is so important. And we're definitely seeing clinically more severe disease in the unvaccinated. We're seeing disease in younger people. Okay, and several studies are suggesting increased admission rates compared to the alpha and ancestral strains. But these are studies that are primarily based on surveillance data. But probably even more important is that the Delta virus entered our community at an opportune time. So remember, as we vaccinated people, okay, there was a lot of unmasking, okay, and many places on the mainland, I can tell you, people just don't mask. Okay, large gatherings are happening. And I think a lot of people, after a year of COVID, really were tired of sheltering in place. They were tired of being in isolation, tired of quarantine, and literally craving for in-person interactions. And I'm sure a lot of you, especially primary care people, have seen this in your patients. Okay, and again, some of the messaging around vaccines, I think, gave people mixed messages that if you just get your vaccine, you can be safe, you can be mobile, you can be non-transmitters. Okay, so that gave us again a sense of security if we were vaccinated. But the Delta has turned that upside down. Okay, and again, what we see of the Delta is that once it gets into an unvaccinated population, it just takes over. And then it is becoming more adaptive because there's submutations occurring within smaller local communities. Next slide. Okay, then this is an important slide. Actually, HPH loaned this to me. Dr. Livaday there gave a talk that I thought was really good, and he showed this slide. So this compares the relative transmissibility, okay, the reproductive number, and then the threshold for herd immunity for various infections. Okay, so all of these are either respiratory droplet transmission or aerosol. And recall that for the COVID virus, respiratory droplets as well as aerosols are important for transmission. But if we come down here to MERS and SARS, you can see that the reproductive numbers are relatively low. And the herd immunity thresholds are really pretty low. Okay, and then comparatively in seasonal influenza and then the 2009 pandemic. So you can see relatively low reproductive numbers. So diseases like measles and chickenpox, though, they're at the other end of the spectrum. So highly transmissible, okay, and you really have to have large percentages of the population immune to reach the herd immunity threshold, like in the 90% range. So the ancestral strain is here. So again, everybody was talking about the 70% goal for herd immunity. Okay, but look at what the Delta has done to us. Okay, so here's the reproductive number, up to maybe 10% at times. And then we're looking at a herd immunity threshold pushing on 90%. And there's some studies that actually have said 90%. Next slide. And this is just another way of showing the relative herd immunity threshold, okay, or what percentage of the population you have to have immune to really unmask. Okay, so here's COVID-19, the ancestral strain. Here's measles and chickenpox. Okay, and the Delta variant is probably somewhere in here. So with our rates of 63% in our community currently, we're really far away if the Delta remains our dominant strain for any significant period of time. Next slide. Okay, so again, this Delta variant is really a huge challenge in how we climb out of this pandemic, okay, and how we, interact with it on a daily basis now. Next slide. Okay, so this is what the state has done. So many of you probably saw this on the news or online. So this is the most recent reopening strategy that the state has put together. So to try to maintain some semblance, I guess, of financial and economic viability for our state, but to deal with the surge and really the state of emergency that's occurring in many hospitals. And I can speak specifically from the Queen's experience. We're dealing with floors in the hospital that are now COVID units that used to be surgical floors. We're dealing with geriatricians, anesthesiologists, working with teams of intensivists. We were dealing with low oxygen supplies at one point. So these things are really meant to limit social interactions more than anything else. And these numbers that they put together here, these are really arbitrary. These are not based on any science. And you can see they tend to choose round numbers, but really to limit social interactions. Next slide. Okay, but these are, I think, more specific strategies to really defend against this Delta variant. So vaccination, vaccination, vaccination. Okay, and there are places, there are companies, there are institutions that are going towards mandatory vaccination. But this really is the only way to develop herd immunity unless you're going to, again, infect your population. And Sweden actually tried that early on to actually encourage their population to get infected, to develop herd immunity. But they realized right away that that's not the right strategy. So really vaccination is the number one strategy to get rid of the Delta variant. Okay, and then wearing your mask. Okay, so this is a barrier protection. And there is now data that suggests that the more layers, the better. But that has to be balanced against, again, a comfort, okay? But having a respiratory barrier in place whenever you're around somebody else. And then frequent hand hygiene. So early on, it was thought that contact and touch were an important part of transmission. It's probably not as true any longer, but there are, again, high touch surfaces that people may come into contact with and touch the mucous membrane areas around their nose, mouth, and eyes that are potentially still sources of transmission. So along with that, disinfecting high touch surfaces regularly. Okay, and then avoiding unmasked people whose COVID status you cannot confirm. Okay, so at those large clusters and social gatherings, these are people who are unmasking in social situations. Okay, so if you don't know the COVID status of other people, wear that mask and socially distance. Okay, and you may need to mask around high-risk friends and family. So if you live in a household where other people in your household and in your family are indulging in high-risk behaviors, in order to protect yourself, you should be wearing a mask. It doesn't matter if they're your cousin or they're your daughter or they're your wife or husband. Okay, if they're in high risk situations or they're unmasking around other people, if you want to protect yourself, you have to wear that mask. Okay, and then avoiding non-essential travel. So again, it's not so much about tourists coming here, it's about our residents going to Las Vegas and going to all of those red places on the mainland. And you can see that pretty much the whole mainland is on fire with COVID, and it's the Delta. Next slide. Okay, and then what can you do for your practice and your patients? Okay, so I think probably a lot of people here are already doing telehealth. So during this surge, that's another way for appropriate patients where the physical exam is not critical to limit your contact, limit those vulnerable patients just going out into public. Okay, and I can't emphasize enough the importance of doing pre-visit screening. So you don't have that coughing COVID patient walking into your office. Okay, so at the time the appointment is scheduled, okay, ask about COVID symptoms, ask about recent travel, ask about known exposures to COVID. Okay, and we've had this sign on our door for over a year that has a simple picture. It's a poster from the CDC graphically showing what are the common COVID symptoms. And at the bottom of the poster, we say, if you have any of these, don't come in our door, call our number and let us decide what we're going to do with you. Okay, and then once people walk into our office, the front desk asks every single person, whether they're FedEx dropping off things or they're our regular patient of 20 years, do you have these symptoms? Do you have a fever? Okay, and we start our triage right there. Okay, and then mandatory staff vaccination. That's all I have to say about vaccination for healthcare workers. And if someone doesn't have a mask, they don't come in, okay? Or we give them a mask immediately. And then educating our patients and our staff on how to wear a mask. And I can't tell you how many people still don't know how to wear a mask. It's below their nose, it's below their chin, okay, or there's gaps in their mask between their face and the mask. Okay, and then for staff and providers, if you think that your encounter is going to last 15 minutes or more, or when examining the oropharynx, wear eye protection. Okay, and it's either safety glasses with the side protectors, a face shield, or goggles. And I have a low threshold for just wearing eye protection in general. And then don't do AGPs, okay, including spirometry in your office, which is considered an AGP. And then have a plan in advance for dealing with infected and exposed staff who might require quarantine or isolation, and a policy for return to work. So there's CDC guidance on this, specifically for healthcare personnel. And then have a plan in place if you have an exposure in the office. So again, breaches in PPE, breaches in procedures do happen. So be prepared to deal with it. Next slide. Oh, next slide. Is that it? That might be my last slide. So I guess Kahea, should I take questions? I don't know if there's things on the chat or.
Yeah, thank you so much for that presentation. It's very educational, Dr. Bello. If anybody has any questions, please feel free to write it in the chat box and we can answer it live.
Or can they ask, are they allowed to unmute themselves?
Erlane, this is Ross. I got a question.
Hi, Ross.
Has Libby, which is I guess the Department of Health here for Hawaii, has she consulted you or your colleagues regarding what would be the best plan of care and suggesting that to the governor? I know Senator Kim kind of put her under the pressure and said, "You are the health person in the state."
Mm-hmm.
So what recommendations can you put to curtail the increase of infections in the state?
Yeah, so I can tell you quite honestly that Dr. Campbell has been working tirelessly to talk to government officials. Jill Green has met, and Jason Chang from Queens have met regularly to apprise them of our hospital situation, both at Queens and at West. But again, they're the ultimate decision makers for policy. So that's all I'm going to say. But I know Sarah Campbell has talked to the legislature, she's talked to city and county, the governor. But again, they're the ones who make the public policy.
Thank you.
Yeah. So I'm being recorded, Ross, so I need to be careful of what I say.
There's another question in the chat box. When do you anticipate vaccines for kids 5 to 11?
Yeah, so I don't know the answer to that. So those studies are still ongoing, but that is another critical strategy, okay, especially with school in session. So again, kids as a group don't tend to get as sick, but definitely those with risk factors, okay, chronic diseases, congenital diseases, metabolic diseases, they're very high risk. And Kapiolani has had its share of children on ventilators. So that's a huge piece of protecting the entire population. So if you have kids under the age of 12 and you have other people living in the household, especially elderly or people with chronic diseases, that these kids going to school unvaccinated are risks for the high risk people in the household. And I don't know if there's any pediatricians on the call who know better than me, but I know those studies are still ongoing. I don't know a specific date, I know the Pfizer vaccine, I think the Pfizer vaccine is probably going to be the first one that comes out for kids just because they had a head start.
Thank you. And a related question, does the Delta variant affect children more severely?
Okay, so that's one of the difficulties with all of these severity studies, because when we look at who's getting the Delta variant, it is the unvaccinated populations. And that's why it's hard to tease out just based on surveillance data. So it's hard to know, but there is some suggestion that again, the Delta variant may hit kids and younger people more severely than the Alpha and the other variants.
Thank you. And then there was another question here. Can you please comment on the efficacy of subcutaneous versus IV infusion of monoclonal antibodies?
Okay, yeah, so definitely the EUA for treatment. Okay, so the EUA, the major study that the FDA EUA for REGEN-COV was done with intravenous therapy. And so that's why the FDA EUA for using REGEN-COV for mild to moderate illness in people who have severe risk factors, they strongly recommend the IV route. So that study looked at the risk of hospitalization and death, okay, from severe disease. There is another study that looked at using the subcutaneous route, okay, in people who had asymptomatic infection being protective against symptomatic disease. So it had a different outcome measure, okay, than the study that looked at the IV therapy. So the EUA does allow for the use of subcutaneous REGEN-COV if you can't get IVs. Okay, so in our protocol at Queens, again, IV is the preferred route for somebody who has mild to moderate COVID disease. Now, if you're talking about prophylaxis, okay, that's a different story. So the prophylaxis studies were primarily through the subcutaneous route, okay, and that is using REGEN-COV in people who are not infected, but who had a significant exposure, who are in a high-risk group. So right now, Queens is not giving it for prophylactic use in uninfected patients. And HPH has taken the same stance, okay, that they're thinking about using it, but they're limiting it right now to people with actually documented COVID for treatment to prevent progression to severe disease, hospitalization, and death.
Thank you, Dr. Bell. Related to that question, mild to moderate disease for Regeneron, what about asymptomatic patients?
Okay, so the FDA EUA right now does not include asymptomatic patients. So if you're following the letter of the law, and the pharmacy just got a notice that the feds are going to be auditing the supply and the utilization. So I know we've had a clamor among our hospitalists to use it in asymptomatic people. But I think right now we're going to be towing the EUA line and limiting it to symptomatic, mild to moderate patients.
Okay, let's take a couple more questions since it's almost 6:45. What about a more aggressive use of monoclonals to contain community transmission?
Yeah, so that would be, again, giving it for asymptomatic or uninfected people. Okay, so right now we're still prioritizing the people who are symptomatic and actually infected. So in long-term care facilities, they're probably the ones who have the most experience with it in SNFs to prevent a outbreak once they identify a case, because pretty much everybody in a long-term care facility or SNF falls into one of those high-risk categories. So I think right now that's probably the biggest use of the subcutaneous route for preventive use after an exposure in a long-term care facility.
Thank you. And do those with previously, I guess if they had a prior COVID infection, when coupled with full immunization, have more immunity?
Yeah, so that's what studies are suggesting, that if you had natural immunity plus vaccination, that gives you the best protection against future strains. Okay, so that's better than natural immunity alone. And we've already seen that, again, natural immunity from the ancestral strain may not protect you against the Delta. And then it seems to be even better than vaccine immunity alone. But again, I don't think anybody's advocating that if you got the vaccine, you should try to get infected to get super immunity. But in people who've been studied, that seems to be the best form of immunity.
Thank you. And I'd also like to point out that Dr. Bello sent out an information sheet that we've emailed to the membership on specific details about the RegenCov that Dr. Bello was referring to.
Yes, so particularly out at West, we're trying to expand our capability. In fact, we're sending some FEMA nurses out there to jumpstart the RegenCov program at West. And for those of you practicing out West, I don't need to tell you where that's the hotbed. It's a hotbed out there of unvaccinated. And that's who we're seeing in our community. And the people who are in the hospital are pretty much the unvaccinated. So if there's any way we can prevent them, the unvaccinated, and get to them in early infection to keep them out of the hospital, which is already overburdened.
Thank you, Dr. Bell. That was highly informative and a lot of riveting questions here. For the sake of time, if anyone has further questions, I guess, could they reach out to you?
Yeah, so yeah, Kahiri, you can share my email with them.
Okay, great. Thank you, everyone. Do you have any closing remarks?
Okay, no, except everybody get vaccinated if you're not. Wear your mask, wash your hands, okay? And don't think that if you're outdoors, okay, you can't get it. Okay, so no large unmasked social gatherings outside, please.
Great.
And when the booster comes, go get it.
And that's like 8 months after your last dose, right? Except if you're immune compromised.
Yeah.
All right, everybody. Thank you so much again, Dr. Bello.
Okay, bye.
Bye.